Hello and welcome back to my channel. My name is Erin and I'm the founder of the Metronidazole Toxicity support group on Facebook. I'm also the creator of the Metronidazole Toxicity blog. You can find links to both in the description below. And today we're going to be talking about the symptoms of metronidazole toxicity, part 2. In the last video, we went through all of the symptoms of metronidazole toxicity and we broke them down from the most common to the least common. In this video, we are going to be talking about why these symptoms are happening in the first place. And in order to do that, we have to use a pretty nasty word, and that is damage. I really hate this word because not only is it extremely scary, but it's also incredibly vague. After all, a gunshot wound can be damaged, but so can a paper cut. I do want to reassure you that most people suffering from metronidazole toxicity do make a full recovery eventually. And the minority that don't, for the most part, do see significant improvements. And I'm in that minority, so I know how scary that can sound. But given how bad my symptoms were in 2015 to where they are today, I feel incredibly lucky. And I'm happy, I feel relatively healthy. So these symptoms have gone from being disabling and debilitating to being a nuisance. But in order to talk about this correctly, we do have to use the appropriate terminology. In this case, this drug does have the potential to cause damage to the body that can trigger symptoms. This information is based off of medical literature, the FDA label, the FDA report, patient reviews, and also the testimony of the 1,000 patients we have in our metronidazole toxicity support group. I still need to put up a disclaimer. I'm not a doctor. Whatever information you take from this video, you are going to have to decide what to do with it and what is best for you. One thing that we will not be discussing in this video are the mechanisms behind the damage that metronidazole is causing to the body. That is a whole new level of information that is going to take its own video to explain. So we're basically doing this backwards. We're going from the symptoms to the damage that is triggering these symptoms, and then the next video we'll be talking about why that damage is happening in the first place. Step 3, step 2, and then step 1. And then we're going to be talking about treatment options. Okay, so now it's time for us to have this discussion. To sum it up very quickly, metronidazole is neurotoxic. It has the ability to damage the back part of the brain, specifically the cerebellum and the brainstem. It can also affect other parts of the brain, like the corpus callosum and the basal ganglia, but for the most part, the most heavily hit region is the cerebellum and the brainstem. In addition to that, metronidazole can also damage the nerves throughout the body, and this is called neuropathy. There are different forms of neuropathy, including optic neuropathy, which is damage to the nerves of the eyes. And then there's peripheral neuropathy, which is talking about the extremities, starting with the hands and feet and going to the arms and the legs, and then potentially to the rest of the body. We will be discussing both of these parts of the toxicity in this video. This is not speculation. This is not an opinion of mine or a theory that I have. This is fact. This toxicity is well established in medical literature, and some of it is even on the FDA label. Central and peripheral nervous system effects. So your central nervous system is your brain and your spinal cord. Your peripheral nervous system is the nerves that run through your body. Encephalopathy and peripheral neuropathy. Cases of encephalopathy and peripheral neuropathy, including optic neuropathy, have been reported with metronidazole. So like I said before, peripheral neuropathy is in your extremities, optic neuropathy is in your eyes, and encephalopathy, this is a word that you've probably heard before and maybe not realized it. So when they had the controversy with the football players getting multiple head injuries that eventually led to a disorder called CTE, that stands for chronic traumatic encephalopathy. Encephalopathy is just a blanket term for brain dysfunction. That's all it means. And there are a number of disorders that fall into that category. When it comes to metronidazole, it's typically labeled as Metronidazole-induced encephalopathy, or MIE. So when it comes to the encephalopathy related to metronidazole, as you see in the second paragraph, it talks about cerebellar toxicity characterized by ataxia, dizziness, and dysarthria. So the ataxia is dealing with motor control issues, and usually with metronidazole, that's going to be in the legs. That's why in the previous video we talked about difficulty walking, having an unsteady gait. That's the manner to which you walk. Uncoordinated walking, these types of things. Now you can have ataxia in the arms as well, but it's more common to have ataxia in the legs when it comes to metronidazole. And there is a reason behind that, and we'll discuss that in the next video. Dizziness, that is a side effect of metronidazole, but it can also be an adverse effect. It can be something that stays after you're done taking the drug. And then lastly is dysarthria, and that is the difficulty speaking, which can be slurred speech, shortness of breath while speaking, and so forth that we talked about in the last video. CNS, that stands for Central Nervous System lesions seen on MRI, have been described in reports of encephalopathy. Central nervous system symptoms are generally reversible within days to weeks upon discontinuation of metronidazole. CNS lesions seen on MRI have also been described as reversible. Okay, so this is where I have to put in a little note. FDA labels are written by the pharmaceutical companies. They are not written by the FDA. And because of that, typically what you'll notice is the language is always going to be kind of glossy, and that comes with any drug. And as you can see here, they use the word reversible twice. When we dive into the literature about it, you're going to see how this is not really painting the full picture. Peripheral neuropathy, mainly of sensory type, has been reported and is characterized by numbness or paresthesia of an extremity. Paresthesia is pins and needles, that tingling sensation that you might have due to nerve damage. And then lastly, convulsive seizures have been reported in patients treated with metronidazole. So this is not just listed on the adverse effects page of the FDA label. These are warnings that have been put on the FDA label. I do want to point out that this specific warning with this type of detail and wording was only put on the FDA label in 2013. This drug has been on the market and approved by the FDA since the early 1960s. The reason why this is on the FDA label is most likely because of this. This is a systematic review that came out at the end of 2011, Metronidazole-induced central nervous system toxicity, a systematic review. This is a collection of case studies throughout the decades of metronidazole being on the market. And in this review, it has busted a lot of myths when it comes to metronidazole, and it has enough information about case studies to form a more coherent understanding of the toxicity, but also statistical data when it comes to outcomes. So we're going to go through this. They had 64 patients with the case studies, and you can see this in green, that 77% had cerebellar dysfunction, 33% had an altered mental state, and 15% had seizures. Now, one thing I want to point out is that this is not based off of what patients are reporting. These case studies are based off of what patients are reporting to their doctors, and then doctors are the ones who have to recognize that someone is suffering from metronidazole toxicity and then report it, either to the FDA or through a case study. And this is what that's based off of, or are these published case studies. Patients, we're going to the red part now, patients' ages averaged from 12 to 87 years, and 64% were male. The median duration of metronidazole was 54 days, although 26% had taken it in less than a week and 11% had taken it in less than 72 hours. We're going to be talking about what this systematic review and other medical literature gets very right when it comes to metronidazole toxicity and what it gets very wrong. And I'm going to tell you one thing that it gets so wrong. 64% of patients are not men. So if you're a female and you're listening to this and you see that says 64% are male, I'm going to tell you right now, that is wrong. And we're going to discuss in another video why it is wrong. Let's go to the yellow part. Among cases with outcome data, most patients either improved, that's 29%, or had complete resolution of their symptoms with discontinuation of metronidazole, that's 65%. So this is where the FDA label gets it correct. The majority of people do have a full recovery from metronidazole, and then the other minority, large minority, 29% like myself, they see improvement. There was no difference in resolution of symptoms by age or sex. The patients with cerebellar dysfunction were less likely to experience complete resolution than those with mental status changes or seizures. So this has to do with the cerebellum related to motor control issues, and we're going to talk about the symptoms related to cerebellar dysfunction versus other problems. Okay, so going to the purple part now. Nearly all patients underwent imaging of the brain. 69% had an MRI, 19% had a CT scan. All patients with cerebellar dysfunction had abnormalities on imaging. That's 93% had a cerebellar lesion, although numerous areas of the brain were affected. On follow-up MRIs, 83% of patients had a complete resolution of the abnormalities, aka of the lesions. So this is the chart that came with this systematic review. And if you look at it very closely, you will see that the neurological manifestation, dealing with, some people had multiple issues, but down the line you see cerebellar dysfunction mentioned multiple times. And this is another thing that medical literature gets right, but gets very wrong when it comes to metronidazole toxicity. It hyper-focuses on cerebellar dysfunction and doesn't focus enough on problems with the brainstem, and we're going to talk about that in a minute. You see people who've had seizures, and then you take a look at the ages on the side, and then also the duration of taking metronidazole. And then at the very end of it, on the very right, neurological outcome, and most people had resolution or they improved. So this is the first page of that. We're going to the second page. And so again, down the line, cerebellar dysfunction is mentioned constantly. You had improvement on a lot of these, and then some resolutions. And then on the final page, almost everyone had resolution or nearly resolved. So this is the other chart that's in this systematic review, talking about other parts of the brain that are affected by metronidazole toxicity, with the cerebellum being at the top and then other parts being at the bottom. But this is what I want to point out. Near the center, you have what's called the midbrain, the pons, and the medulla. All three parts of this, those three sections, are your brainstem. They're different regions of your brainstem. And finally, we're going to talk about the median duration of metronidazole was 54 days, although 26% had taken it less than a week and 11% had taken it in less than 72 hours. And what the conclusions of the systematic review say, and this is important for any patient that's listening, but also any physician, the dosage and the duration are not correlated with the toxicity. It does not correlate. The dosage and the duration do not matter when it comes to metronidazole. Somebody could have a toxic effect within a day of taking this. We've seen it in our support group. We did a qualitative survey of patients and asked them when they had that initial reaction. And if you were suffering from metronidazole toxicity, you know what I'm talking about. It's the moment when you feel like something was really wrong with your body. There were a number of different options, from 1 day to 2, 3, 4, 5, 6 a week, 2 weeks, 3 weeks, a month. We had about 15 options listed, going up to 6 months taking metronidazole. The results came back. There were very few people who responded who said that they suffered their initial reaction later than 2 weeks on metronidazole. This is another thing that we need to point out with this systematic review. It very much highlights the abnormalities on the MRI. And these are lesions called white matter lesions on an MRI. And this is basically encephalopathy. It is an injury that you see on the scan that is related to the toxicity of this drug. According to this systematic review, there was poor correlation between symptom outcome and MRIs. The MRI abnormalities resolved even when symptoms persisted. And at the bottom, an improvement in symptoms preceded or followed changes in MRI findings. And this is so important to point out here, because basically what this is saying is that the appearance of these lesions and the resolution of these lesions do not match up with the resolution of symptoms, which means that these lesions are a poor indicator of metronidazole toxicity. But in medical literature, they are vastly highlighted. And we're going to talk about that at some point in another video, why that is. Metronidazole toxicity should never be diagnosed strictly if someone has a lesion on an MRI, especially if they've stopped taking this drug. Because some people, these MRI scans happen 3 days after they stop the drug and the lesions are gone even if symptoms persist. And for the vast majority of people in our group, they do not get an MRI until weeks to months after they have discontinued the drug. So it is especially a poor indicator if you've stopped taking the drug. Now we get into the other aspect of metronidazole neurotoxicity, and that is damage to the brainstem. And that is something this systematic review that we just looked at really underappreciates, and instead they hyper-focus on the cerebellar dysfunction. And again, we'll talk about why in a minute. So this is MRI imaging of metronidazole-induced encephalopathy, lesion distribution, and diffusion-weighted imaging findings. Okay, so I know that's a lot of words there, but pretty much what they did was they did an MRI, which, like I said, MRI is a poor indicator of metronidazole toxicity because you can have the symptoms and not have the lesions. Because if the lesions disappear and the symptoms persist, obviously something else is going on. But this is at least something because it shows that this drug is affecting the brain. There's actually a test that will sometimes indicate that yes, there is damage. It causes white matter lesions. We can see it on an MRI. So it's still important to look at because it gives an idea of where the damage mostly is. And in this case, it's the cerebellum and the brainstem. So that's what this other systematic review, this is a smaller systematic review, a smaller collection of case studies, but still definitely worth looking at because if you look at the results and conclusion, they had 7 patients, and of the 7 patients that they suspected had metronidazole toxicity, all 7 of them had lesions on their cerebellum, which is their cerebellar dentate nucleus. I hope I pronounced that right. But look at the next part. All 7 of them had lesions on their midbrain. 6 out of 7 had them on their dorsal pons, and 4 out of 7 had them on their medullas. All these 3 sections here that are highlighted, that is your brainstem. And then it goes into further detail about other parts of the brainstem lesions underneath that line of smaller areas of the brainstem that are affected. And if you look at the conclusion at the bottom there, brain lesions were typically located at the cerebellar dentate nucleus, midbrain, dorsal pons, medulla, and splenium of the corpus callosum. So the corpus callosum is the tissue that connects the 2 hemispheres of the brain. According to DWI, most of the lesions in MIE, and MIE again is metronidazole-induced encephalopathy, probably corresponded to areas of vasogenic edema, whereas only some of them located in the corpus callosum corresponded with cytotoxic edema. And we're going to be talking about that, the edema, near the end of this video. So we're going to focus right now on the brainstem. Now we're looking at the chart that comes with this information. And you can see on the left, you have the 7 patients. All of them have lesions on the cerebellum. But then when you look at the brainstem, the medulla, pons, and midbrain, all of them had a part of their brainstem affected by this drug. Now let's look at another systematic review. Acute metronidazole-induced neurotoxicity, an update on MRI findings. So this one just came out. This is from Clinical Radiology 2020. And this is the chart that it has. And again, this one actually has a small group that they studied and then a larger collection of case studies. And I want you to take a look at, again, you have the dentate. If you look near the center, it says symptom resolution, and then right after that, it says dentate, pons, midbrain. Okay, so that is dentate is your cerebellum, med is your medulla, pons, the pons, midbrain. Then you have the CC, that's the corpus callosum. So again, if you take a look at the 3 sections of the brainstem, on almost every single patient, they had some lesions on the brainstem, as well as having them on the cerebellum. But again, if you look at the presentation, it's very generic: encephalopathy, gait instability. Gait is the manner to which you walk. Vertigo, that's the dizziness. Left extremity weakness, ataxia, headache. You have one person here with an altered mental state, and then you have one person at the bottom that had peripheral neuropathy, and you can see that they didn't have a resolution, so we'll talk about that. This is the next chart that they have, and this is a collection of the case studies that they have put together. And as you can see, you have the symptoms: ataxia, AMS is altered mental state, polyneuropathy, dysarthria, that's the difficulty talking, ataxia, and as you can see, it says something called dysmetria. That is similar to ataxia. It's another motor control issue. And you'll notice this, the hyper focus on the motor control issues that are typically associated with cerebellar dysfunction. And if you go down this chart, you'll take a look and see that, you have the dentate, again, that is the cerebellum, medulla, pons, midbrain. And of those, almost every patient has lesions, not just on their cerebellum, but also their brainstem. Now that we've gone through this medical literature that I know was quite daunting, and this is not the only medical literature when it comes to the central nervous system effects. We haven't even touched on the peripheral neuropathy yet, not really. It can be very overwhelming. That's why I want to stop with the medical literature here. I think that I've proven my point. So now let's move on to how this is related to the symptoms that you're experiencing. When it comes to medical literature, the region of the brain that is most discussed is cerebellar dysfunction. So let's start there. These are the symptoms that we talked about in the last video, now reorganized, that fall under cerebellar dysfunction. Dizziness is associated with cerebellar dysfunction, but it can also be associated with other problems. But since medical literature puts dizziness, aka vertigo, with cerebellar dysfunction, that's where we're going to put it as well. Brain fog, this is deficits in attention. That's also something that can be related to cerebellar dysfunction. Difficulty walking, the weakness in the legs, that is ataxia. And that is directly related to cerebellar dysfunction. But you can have weakness and fatigue that's related to overall brain dysfunction, aka encephalopathy, and also dysfunction of the brainstem. But that in coordination, the difficulty using your legs, the wide gait, you're walking strangely, you have an unsteady walk, that is typically related to motor control issues of cerebellar dysfunction. The tremors, I told you in the last video that I was going to share my video of my tremors in my hands. And forgive me, I was not feeling well at this time. It was taken not when I had my initial reaction, but actually about a little over 6 months after I was having a flare-up of my symptoms. And my my house was a little in disarray because I didn't feel well. So please forgive the mess, and I'll go ahead and show you the video now. I noticed that my left hand is trembly again, and I thought it'd be a good idea to show it both with my coffee mug and also my cell phone. So right now I'm holding my cell phone with my right hand. I pick up my coffee cup, and you can see weird little, the longer I hold it, the worse the tremble gets. Now I'm going to switch and hold my phone with my left hand. Right hand. That is related to motor control issues of the cerebellum. Your cerebellum controls the fine motor controls of your body. While most motor control comes from the basal ganglia, which is connected to the cerebellum, it gets filtered through the cerebellum that fine-tunes the motor control. So when the cerebellum is not working correctly, that's when you start to get this fine motor control issues, tremors, the difficulty walking. This can also cause changes in vision due to a lack of focus and lack of visual acuity. Muscle twitches, motor control, difficulty speaking, dysarthria, motor control, difficulty swallowing. That can be related mostly to motor control, but there is something related to the brainstem that can also cause, or at least contribute to difficulty swallowing, and we'll talk about that in a minute. Rapid eye movement. So this is something that is related to the motor control issues of the cerebellum. I also put brain zaps in here and convulsive seizures, and I'm going to leave these two alone for right now. We're going to talk about them in a minute, but those are related to cerebellar dysfunction. So now let's talk about the effects of metronidazole toxicity on your brainstem. So your brainstem has a very special function. It controls all of the automatic things in your body. This includes your heart rate, your blood pressure, your respiration, your temperature regulation, sleep regulation, all of that. Anything that is automatic, it is related to the brainstem and what is called the autonomic nervous system. Technically speaking, your autonomic nervous system is classified under your peripheral nervous system. And this is because it is a nervous system. It goes throughout the body. It sends signals out to the target organs, including the heart and the lungs and your digestive tract. Now, of course, metronidazole has the capability of causing damage or dysfunction to both the central nervous system and also the peripheral nervous system. But in the case of your brainstem, it also has a role when it comes to what is called autonomic dysfunction. But before we get into that, we need to break down the autonomic nervous system a little bit. So your autonomic nervous system actually has 3 divisions. But for the sake of simplifying this, we're going to focus on the 2 big ones. And that is your parasympathetic nervous system, which is your rest and digest, and your sympathetic nervous system, which is your fight or flight. These systems work opposite of each other. They oppose each other, but it's not like they are enemies. It's more of a friendly battle. It's more like Opposites Attract by Paula Abdul, where they might do opposite things, but they still work together in order to keep you properly balanced. Your parasympathetic nervous system, its role is to manage your heart rate, to decrease your heart rate at a relaxed state, about 60 beats a minute, decrease blood pressure, decrease respiration rate. This means a relaxed breathing. It allows for digestion, appetite, urination, and defecation. It stimulates the salivary glands, and it triggers storage of nutrients. Now, this is a very simplified list. There are so many other things that are related to the autonomic nervous system, such as your pupils dilating or contracting. That's obviously an automatic thing that your body does, and so forth. But for this video, to keep it from not going on for another hour, we're going to simplify it a little bit. The sympathetic nervous system, it increases heart rate, it increases blood pressure, it increases airflow, it halts digestion, including appetite, urination, and defecation. It decreases saliva production. It increases sweat production. It triggers alertness, which this stimulates. It directly stimulates your adrenal glands. And it burns through blood glucose and nutrients. Now, if you are suffering from metronidazole toxicity, I know that you're starting to see where I'm going with this. So where are these systems located if they're part of the peripheral nervous system? Well, even though they have their own nervous system, they still have to originate from somewhere. Your sympathetic nervous system originates in your spinal cord, in your thoracic and lumbar spine. So I know that you're looking at this and going, no, wait a second. This is the system that's going berserk. I'm having constant adrenaline rushes, anxiety, heart palpitations. I'm air hungry. I can't eat anything. My digestion is halted. So what point does this have when it comes to your brainstem? Well, actually, your sympathetic nervous system doesn't really seem to be the problem here. The problem is where your parasympathetic nervous system is located, and that is in your brainstem. It's also partially located in the lower part of your spinal cord, but it is directly within your brainstem. In fact, if you look at this diagram, look on the left side, you can see where it talks about the midbrain, pons, and medulla contain parasympathetic nuclei associated with cranial nerves 3, 7, 9, and 10. What is happening is that your sympathetic nervous system seems to be working okay. It probably is not severely affected by metronidazole toxicity, although everybody is different. Most likely it is your parasympathetic nervous system that has been compromised due to dysfunction or possible damage to the brainstem. Now let's take a look at the cranial nerves. So this is cranial nerves 3, 7, 9, and 10. So cranial nerve number 3 is your ocular motor nerve. The ocular motor nerve has 3 main motor functions. The innervation of the pupil and lens, that's the autonomic parasympathetic, the innervation to the upper eyelid, innervation of the eye muscles that allow for visual tracking and gaze fixation. So once again, we find another issue with vision, and this is not the only issue that could affect vision. So cerebellar dysfunction could cause some problems with visual acuity, with attention and so forth. But now you also have your brainstem affected with the parasympathetic nuclei that are located in the brainstem and controlling these 4 major nerves. So the next one is the cranial nerve number 7. The facial nerve emerges from the pons of the brainstem, controls the muscles of facial expression, and functions in the conveyance of taste sensation from the anterior 2/3 of the tongue. The facial nerve also supplies preganglionic parasympathetic fibers to several head and neck ganglia. So if you have metronidazole toxicity, you will notice that you have a lot of issues related to your face and your head. How this is related to the cranial nerve, it's not been researched well enough to truly know. We just know that your brainstem has been somewhat compromised due to metronidazole toxicity that is affecting your parasympathetic nervous system. So now we go to cranial nerve number 9, which is your glossopharyngeal nerve. I went ahead and showed the dysfunction related to it. I thought that would probably be easier to grasp. And so lesions produce difficulty swallowing. impairment of taste over the posterior 1/3 of the tongue and palate, impaired sensation over the posterior 1/3 of the tongue, palate, and pharynx, an absence of gag reflex, and dysfunction of the parotid gland. So your parotid gland is 1 out of 3 of your salivary glands. And then lastly is your cranial nerve number 10. And this is your vagus nerve. And if you look at vagus nerve, you Google that, you will see so much research and dedication to learning more about it, because it is the central nerve related to autonomic function. The vagus nerve represents the main component of the parasympathetic nervous system, which oversees a vast array of crucial bodily functions, including control of mood, immune response, digestion, and heart rate, and also, and this is respiration. It establishes one of the connections between the brain and the gastrointestinal tract and sends information about the state of the inner organs to the brain via afferent fibers. Obviously, this is a crucial part of the brainstem and part of the cranial nerves. And this is directly related to your parasympathetic nervous system. One thing that I do want to point out here is that although we are hyper-focusing on these particular cranial nerves and the parasympathetic nervous system that is compromised, other parts of the brainstem and other cranial nerves can potentially be affected due to metronidazole toxicity. And we're going to be talking about that more in the next video. Now that we've looked at the cranial nerves, I know that you are seeing a picture here. And basically what it is that your parasympathetic nervous system is not functioning properly. And because of that, your sympathetic nervous system is taking over everything. There is no more balance there. Your sympathetic nervous system is dominating. Let's go ahead and take a look at the symptoms of autonomic dysfunction, aka dysautonomia, that we discussed in the previous video, now reorganized into its appropriate category. So the first list that we're going to look at here is are the physical symptoms, and then after that we'll look at the neuropsychiatric symptoms. So we have nausea, anorexia, and weight loss, of course. If you are trapped in your sympathetic nervous system, your digestion has come to a halt. Because if you're stuck in your flight or fight, your body is not interested in digesting food. It is interested in running away from the danger. It goes beyond a loss of appetite. You've lost the will to eat. You don't feel hungry. It's because your digestive tract has basically come to a halt. The next one is constipation or diarrhea. Typically, if you're stuck in your sympathetic nervous system, then you are going to have constipation because of the halt of digestion. However, we know that some people, that's not the way that their bodies react. Some people have defecation when they have anxiety, like some people urinate when they have a lot of anxiety. And also, when you take an antibiotic like metronidazole, it is not uncommon to suffer from an imbalance of your gut flora, and that could also cause diarrhea. So this is not an exact, you have to have all of these things happen to you in order to be trapped in your sympathetic nervous system. It's not like that. Next one is heart palpitations. Obviously, your heart is racing in your chest, but it's not just the dysautonomia that could potentially be causing the heart palpitations, and we'll talk about that a little further in this video. Changes in blood pressure. Typically, someone has one extreme or the other. They either have hypertension, which would be more common with being trapped in your sympathetic nervous system, but that's not always the case. Remember, it's not just a matter of being trapped in your sympathetic nervous system. Your autonomic nervous system has been compromised. It is imbalanced. And so you might find that you have all these symptoms that are part of the sympathetic nervous system, and then you have a couple of ones that seem like your parasympathetic nervous system is dominating a bit and having that imbalance there. And it's very individual. So as an example, even though I was trapped in my sympathetic nervous system, I had so many of these symptoms. I had difficulty breathing and heart palpitations, but my blood pressure was low. I actually had hypotension, not hypertension. And in fact, I have a couple of photos I took during that time period to show my blood pressure in July of 2015. So this is about a month after I had my initial reaction. So normal blood pressure at the lowest should be 90/60. And as you can see here, mine is considerably lower. And this was when I was dealing with horrible anxiety, insomnia, heart palpitations, hard heartbeat, all of that. And I still had hypotension. It just didn't make sense. And sometimes these things don't make sense. We don't know exactly why one happens and the other one doesn't. The next one is difficulty breathing. A lot of times you'll notice breath holding, like I said in the last video, but also being very air hungry. And again, this is a part of dysautonomia. Your respiration is controlled by your autonomic nervous system and your brainstem. So you're going to find that it's going to be imbalanced, that you're going to be holding your breath, or you're going to be very air hungry and gasping for air, dealing with this issue. The next one is loss of libido. Now, I actually forgot to put this one on the last video. I knew I was always going to at least miss one symptom. But your libido is actually controlled by both your parasympathetic and sympathetic nervous system. And it's a good example of how both these things, even though they're opposite, work together. So your sympathetic nervous system handles when you climax. But in order to even think about sex, you have to be in your parasympathetic nervous system. You have to be calm. You have to feel safe and relaxed. So you will have no interest in sex if your parasympathetic nervous system is compromised. The next is temperature regulation. So again, this is handled by your autonomic nervous system, how hot you feel. With me in particular, I noticed that my face felt like it was flushed, and considering how your facial nerves are controlled by your parasympathetic nervous system and the cranial nerves, that actually makes a lot of sense. So you might notice that your face is flushing, or your body feels really cold, or your body feels really hot. Okay, so the next four are related to each other. It's dry mouth, white tongue, sore throat, and difficulty swallowing at the top there. The reason why you would have dry mouth is because when you are trapped in your sympathetic nervous system, your salivary glands are not producing enough saliva. Again, you are stuck in your fight or flight mode. And it is a part of your digestion of food is having saliva. And so that comes not to a halt, but definitely it's greatly decreased. And it's one thing to have that decreased for 20 seconds or 2 minutes while you're dealing with some type of threat. It's quite another to deal with it for weeks or months. So one of the consequences of having a dry mouth is that you could end up with something called white tongue. And this could be on just your tongue, or it could be coating your entire inner part of your mouth. But basically what happens is that because you aren't producing enough saliva, grime builds up within your mouth and on your tongue that it's not getting washed away. Now, it could potentially be due to a fungal infection, a candida overgrowth. And if that's the case, you might be able to go to the doctor and get a prescription for an antifungal mouthwash and see if that takes care of it. However, I know people that have done this and have not had any success with it, but it's at least good to eliminate that possibility. So that's the reason why you could potentially have white tongue in relationship to dysautonomia. The next one is sore throat. So again, if you have dry mouth, but also when you are stuck in your sympathetic nervous system, your airway will dilate. This is due to the overproduction of adrenaline, aka epinephrine, and that will keep your airway open wider than it normally would be. Now again, having that happen for a couple of minutes is one thing, but when you are stuck in panic mode for weeks or even a couple of months, eventually that air hitting the back of your throat constantly because of this dilated airway will potentially start to cause irritation. That can also contribute to the difficulty swallowing. Now again, your difficulty swallowing is also related to cerebellar dysfunction, and also a dysfunction of the parasympathetic nuclei that are associated with cranial nerve number 9. So all of that can be related. Okay, changes in taste and or smell. There's a lot of parts of the brain that process taste and smell. Your olfactory nerves is an example, but if I had to categorize them into anything, I put them under general brain dysfunction as well, but if I had to narrow it down, I definitely would put it under dysautonomia. Obviously because of its relation to the cranial nerves that would be affected if your parasympathetic nervous system was compromised. Changes in vision. This has to do with cranial nerve number 3 being affected. And then also, you could also potentially have optic neuropathy, which is the nerves that actually go directly to the eyes. And then there's also another aspect of it dealing with cerebellar dysfunction and processing visual acuity. They could all be related. So you have 3 different factors that can cause changes in vision, not just one. Excessive thirst and frequent urination. So this is actually related to the imbalance of electrolytes. But specifically when it comes to dysautonomia, it's the imbalance of sodium. So this has to do with something called cerebral salt wasting syndrome. And this is in relation to dysautonomia, where your body is not properly retaining enough sodium in order to function properly. And so you could find that you might have a complete loss of appetite, but if you're going to eat anything that you can tolerate, it might be something salty. I know that of all the things that I wanted to eat when I was really sick, ramen noodles were my top choice. And of course, those are loaded with sodium. And frequent urination is because when you can't retain the sodium, then your body gets rid of it through urination. So this certainly isn't with everybody, but this is something that can happen. Excessive sweating or lack of sweating. Typically, if it's on the sympathetic side, it's going to be excessive sweating. But like I said, some things that are related to your sympathetic nervous system, you might find that you have 1 or 2 symptoms showing a dominance of your parasympathetic nervous system. And the last one on here is POTS. And POTS stands for postural orthostatic tachycardia syndrome. And this is again related to the autonomic dysfunction, where your autonomic system can't properly regulate your heart. So when you stand up and gravity takes over and your autonomic nervous system is not working correctly, then for some individuals, especially ones with extreme cases of metronidazole toxicity, their heart does not compensate for the gravity and the blood pools in their feet as opposed to going to their brain. This causes extreme dizziness and possibly fainting. Okay, so now that we've gone through the physical symptoms of dysautonomia, let's talk about the neuropsychiatric symptoms related to this. And like I said, these are so severe that they really deserve their own category of an altered mental state, but they are a part of autonomic dysfunction, aka dysautonomia. So you have anxiety, obviously. If you are trapped in your sympathetic nervous system, is going to stimulate your adrenal glands, overproduce adrenaline, and you're going to have adrenaline rushes constantly. And this is going to keep you in your fight or flight response. This, of course, in turn is going to lead to obsessive thoughts. Obviously, if you cannot rest in your parasympathetic nervous system, then you're going to have your brain just not quiet. The next one is nightmares. That one I don't think needs much explanation. Next one is insomnia. Now there are a couple of other things related to insomnia, difficulty breathing, and heart palpitations that are outside of dealing with just dysautonomia, but your autonomic nervous system regulates your sleep. And if it is dysfunctional and you are trapped in your sympathetic nervous system, obviously going through your fight or flight response, sleeping is very, very difficult. Now, on the flip side of that is extreme sleepiness. So, like I said before, there's 1-2 people out of 100 that suffer from metronidazole toxicity, that instead of being trapped in their sympathetic nervous system, they actually get dominated by their parasympathetic nervous system. And why that is, we don't really know. But I've seen a couple of cases of it talking with people suffering from metronidazole toxicity. People that are stuck in their parasympathetic nervous system typically have extreme sleepiness, fatigue, depression, lack of motivation, lack of interest. So there's a lot of different symptoms that are horrible being stuck in your parasympathetic nervous system. Now, when you're stuck in your sympathetic nervous system, you could also have depression. And like I said before, depression is typically a delayed symptom if you are stuck in your sympathetic nervous system, because it's really, even though you do have lack of emotional control when you have dysfunction of your autonomic nervous system, depression comes on when you take this drug and you have all of these horrible symptoms, you have massive anxiety, but then you stop taking the drug and everybody tells you that you should be fine now, and you're not fine. And you're confused by this. And after dealing with this horrible anxiety and this altered mental state for a couple of weeks, maybe a month or so, you start to feel helpless and you start to feel hopeless. And this can easily lead to depression. Also, a paradoxical symptom is fatigue. So it sounds like, how can you have fatigue if your fight or flight response is on overdrive, that it's taken over? Shouldn't you constantly be alert? So let's take a look at another diagram. And this one shows the sympathetic receptors. And if you look on the right side where it says epinephrine, that's adrenaline. I want you to take a look at that little yellow circle. It says ATP. So ATP is a short name for the energy of your body. So when you eat food and it gets converted into energy, that energy is called ATP. And when you are stuck in your sympathetic nervous system, you burn through that energy very quickly, just like you burned through nutrients very quickly. You're basically running on fumes, especially if you're not eating right and you can't sleep. You aren't restoring anything. So in response to that, you're going to suffer from extreme fatigue because your body just can't handle the amount of energy that your sympathetic nervous system is forcing it to go through. And the next one is derealization and depersonalization. So there are two things that could cause these symptoms, which is a detachment from your surroundings, derealization, or a detachment from your body, which is depersonalization. And that is that because of all the anxiety and the panic and being stuck in your flight or fight response, that your body is trying to protect you and trying to calm you down, and it's trying to detach you from whatever traumatic thing that you're going through. And that includes detaching you from your surroundings or even your own body. The second aspect of this could be that, that your consciousness itself is being affected, because consciousness is a part of your brainstem. This can, of course, cause mental confusion, paranoia. If you have obsessive thoughts and anxiety, it's not a stretch to think that you would have paranoia. Light and or sound sensitivity. So your stress threshold has been lowered greatly because of being stuck in your sympathetic nervous system. Any stimulus, including a bright light or a loud sound, could trigger adrenaline rushes and panic and an overstimulation because you don't have the parasympathetic nervous system to calm all that down. Next is hallucinations, which is where you're going more towards the unreality side of things, although a lot of people recognize when they're hallucinating. That is a little bit of a less common symptom. Suicidal thoughts. We've talked about this in the last video. And in my opinion, suicidal thoughts, while I know that it's related to the emotional instability that you're going through, I believe that this is more of an environmental factor, because people with metronidazole toxicity do not get the support they need. sometimes from their family, but especially from the medical community. I will talk about this in another video, but most of the people in our support group are not believed by their physicians. And even if they are believed, their physicians don't know how to help them. So we're going to be talking about the mechanisms behind this toxicity in the next video, and we're going to be talking about possible treatment options that will hopefully help you as you're trying to move past this. The last one is psychosis. This is not the same as having an altered mental state. Altered mental state is more the anxiety and paranoia and other things where you know logically it doesn't make sense, but emotionally you feel all over the place. Psychosis is a total break from reality, and we talked about that in the last video. So these are the symptoms of dysautonomia related to metronidazole toxicity, of you being trapped in your sympathetic nervous system due to your parasympathetic nervous system being compromised due to its location in the brainstem. So before we go on to miscellaneous symptoms related to encephalopathy, I wanted to discuss why cerebellar dysfunction is so hyper-focused in medical literature, and autonomic dysfunction is not even discussed at all. Well, I want you to take another look at the symptoms of cerebellar dysfunction. You have motor control issues. You have potential seizures. You have difficulty speaking. I lost the ability to walk and speak when I was dealing with metronidazole toxicity, and even with those symptoms, my doctors failed to recognize what was really going on. But just imagine that you have a patient who comes into the office and they don't have cerebellar dysfunction, but instead have autonomic dysfunction due to metronidazole toxicity. And they come in and say, doctor, I'm having horrible panic attacks. I can't calm down. I can't sleep. I can't eat. My throat is dry all the time. My face feels hot, like it's on fire all the time. My heart is racing in my chest. I don't know why. I can't breathe. I feel like I can't breathe. What the doctor will typically hear is this. They will relate almost all the symptoms that are associated with autonomic dysfunction to anxiety. They will blame the symptoms on anxiety, believing that anxiety is the underlying cause, even if the patient has no medical history of an anxiety disorder before this. Instead of realizing that anxiety is just one other symptom of metronidazole toxicity. This is another reason why seizures, dealing with cerebellar dysfunction, going back to the original medical literature that we looked at, the first systematic review that we looked at, pointed out that 15% of patients had seizures. And I'm telling you right now that seizures are extremely rare, but they are easily recognized, and that's the problem. So a patient comes in with severe autonomic issues and doesn't get treated because those symptoms can all be dismissed as something else, as horrible as they are. But if somebody has a convulsive seizure, that is almost impossible to dismiss. That is why seizures come up in so much medical literature when it comes to metronidazole and when it comes to autonomic dysfunction, despite the fact that there is medical literature pointing out that this drug damages the brainstem. There is not a peep. Now, for people suffering from metronidazole toxicity, one thing that you might have noticed, it can show up a few weeks after you stop taking the drug. It doesn't happen with everybody, but it's something to note, are brain zaps. So brain zaps are described as electrical shock sensations in the brain. They can happen in a person who is decreasing or stopping their use of certain medications. Brain zaps are not harmful and will not damage the brain. However, they can be bothersome. Yeah, that's a word for it. Disorienting and disruptive to sleep. Now, if you're dealing with brain zaps, that description does not fully cover it because it's terrifying, it's disorienting. And like I said in the last video, when I had it happen to me, I thought that I might be dying. A lot of times brain zaps are associated with antidepressants. But here's the problem. They happen with a lot of other things that are not related to serotonin at all, including other medications that can trigger them. Another group of people that I'm going to be discussing in other videos are people suffering from fluoroquinolone toxicity. This is another class of antibiotics that includes Cipro, Levaquin, Evolox, and several more. And when people suffer from fluoroquinolone toxicity, brain zaps are also common. So it is not related to serotonin. It's not just a problem with withdrawal from antidepressants. And there was a wonderful article that came out in Psychology Today, and they tried to theorize what the brain zaps could be, and their conclusions is what I also believe they are. So this is from that article, and I will link it below so you can read it entirely. As low levels of GABA can trigger seizures, this hypothesis leaves open the possibility that the reported brain zaps are instances of brief, localized seizures. Seizures are the result of overexcitement in a small isolated group of neurons. A seizure occurs when the hyperexcitement of a small group of nerve cells spreads to larger brain regions. In a grand mal seizure, the excitement of one or more neurons has spread to the whole brain. When most or all of the brain is overexcited, the brain's neurons send signals to the body in an uncontrolled way. This can result in severe convulsions and a loss of consciousness. What this article theorizes is that instead of having convulsive seizures, that brain zaps are actually very small instances of these brief localized seizures. And based off of looking at support groups for people who have seizures, looking at other toxicities, including fluoroquinolone toxicities and benzo toxicities, I absolutely agree with this theory. I did not have serotonin withdrawal when it came to metronidazole toxicity, and I still had these brain zaps. So if you're a doctor listening to this, I think this is something that would be very interesting for you to look into. Now that we've discussed the cerebellar dysfunction, the autonomic dysfunction, why cerebellar dysfunction is so hyper-focused in medical literature and autonomic dysfunction isn't even mentioned, we're going to go into the miscellaneous symptoms of metronidazole toxicity. The headaches and head pressure. We're going to get back to that one in a minute. Neck pain and stiff neck, very common with brain lesions. And your brain lesions, that damage to the cerebellum and the brainstem, that is at the back of your head. That's why you have that pain at the base of your skull. Shoulder and or back pain. This can also be caused because of that, but typically the neck pain radiates down to the shoulders. It doesn't typically go further than that. So the back pain could be related to the muscle aches and muscle atrophy. I'm not going to get into a whole lot of details here in this video. We're going to have to talk about it in the next video. Metronidazole can directly damage muscle tissue. This a lot of times is felt in the extremities, but it can also be felt in the back. This has to do with the cellular issues of metronidazole toxicity. Heat intolerance, exercise intolerance. These are more triggers of your symptoms than they are symptoms themselves, but since it's something that obviously limits you and debilitates you, I think it's worth noting here. Imbalance of electrolytes. Having encephalopathy will do that to somebody. If you have brain lesions, if you have brain damage, your body can't properly regulate things like electrolytes or minerals, then you're going to have imbalances. In fact, it's very common with white matter lesions to have issues, especially with things like potassium, like I talked about before, and also sodium, dealing with cerebral salt wasting syndrome that we'll talk about in the next video. Changes in the appearance of urine, we still don't know exactly why that happens. It could be something related to the kidneys, but we just don't know. Memory loss. Overall brain dysfunction can cause issues with memory loss. It's hard to tell if it's from autonomic dysfunction or cerebellar dysfunction or something else. It's less common to have memory loss. It's more common to have lack of attention, lack of focus, but to have full-blown memory loss is a little more unusual. And then edema. So that's the swelling in the limbs, heart, brain. So in the last video, I need to make a little bit of a correction. I said that edema was a less common symptom, and that is true to have edema throughout the whole body, but here's the thing. When you have brain dysfunction due to injury to the brain, it is relatively common and also noted in medical literature when it comes to metronidazole toxicity to have brain swelling. And there are typically two noted types of brain swelling, and that is the vasogenic edema and then the cytotoxic edema. So that's why I wanted to point this out, is that while having the edema throughout the entire body is less common, having your headaches and your head pressure sensation, there's a term for that. It's called intracranial pressure. And it is related to the encephalopathy, to the brain dysfunction or possible damage that this drug has done that could in turn cause some swelling. So what is brain swelling? Brain swelling goes by many names: brain edema, elevated intracranial pressure, cerebral edema. Swelling can occur in specific locations or throughout the brain. It depends on the cause. Wherever it occurs, brain swelling increases pressure inside the skull. That's known as intracranial pressure, or ICP. This pressure can prevent blood from flowing to your brain, which deprives it of the oxygen it needs to function. Swelling can also block other fluids from leaving your brain, making the swelling even worse. Damage or death of brain cells may result. And going back to the definitions of the specific types of edema. Cellular cytotoxic cerebral edema refers to cellular swelling. It is seen in conditions like head injury and hypoxia. It results from the swelling of brain cells. Now, basically what this means is that the cells themselves are swelling. When it deals with vasogenic cerebral edema, it refers to fluid buildup around the brain. It is the most common type of brain edema. I'm going to go ahead and let you take a look at this for a second. In the case of metronidazole toxicity, you can see both of these types of edema. And in fact, this is from a case study from one of the systematic reviews that notes the vasogenic edema of metronidazole toxicity. And of course, we refer back to the original systematic review that we had looked at before. This conclusion included the noting of the lesions on the corpus callosum that's corresponded with cytotoxic edema. I cannot say for certain whether your head pressure is due to these issues, but if you have brain damage due to metronidazole toxicity, then it is possible that the intracranial pressure is due to a buildup of fluids either within the cells or around the brain. So what are the symptoms of brain swelling? Headaches, head pressure, neck pain, stiffness, dizziness, irregular breathing, vision loss or changes, memory loss, inability to walk, difficulty speaking, stupor, seizures, and loss of consciousness. A lot of these symptoms overlap the symptoms of autonomic dysfunction or cerebellar dysfunction when it comes to metronidazole toxicity. One thing that I do want to note that we will discuss in the next video is something called hypoxia. Hypoxia is where you're not getting in enough oxygen. And sometimes this is referred to as hypoxia, or in the case when we talk in the next video, of pseudohypoxia. But when it comes to metronidazole toxicity, it is not due to having a blocked airway that's causing you not to get oxygen to your lungs. It is a problem of not getting enough oxygen to your cells. Your cells are not properly absorbing oxygen. Some of the symptoms that we've noted when it comes to hypoxia related to metronidazole toxicity: the jolt awake insomnia, where you start to drift off, you start to relax, your heart rate starts to go down, and all of a sudden you jolt awake and you're breathing heavy and you're dizzy and you feel disoriented. Your panic is spiked. Your heart is now racing in your chest and you feel like you just need to take in so much air. You're so air hungry. Also dealing with general air hunger, exercise intolerance, heart palpitations, hard heartbeats, and all of this can lead to anxiety because, let's face it, when your body is suffocating for oxygen, just like if you had an obstruction in your throat, you are going to panic. So why would you have the heart palpitations and the hard heartbeats? Your heart is overcompensating for the lack of oxygen. It cannot get enough oxygen into the cells. So in order to compensate for that, it is beating faster and it is beating harder to get more oxygen into your body to compensate for the hypoxia, for the lack of oxygen that's being absorbed into your cells. This can, in long term, lead to an enlarged heart and other health conditions. Now, right now, at this moment, you probably don't have an enlarged heart. But it is possible that if this does not resolve, that over time, due to your heart having to work so much harder to get oxygen through to your body, that it might cause an enlarged heart down the road. One thing that I did when I was suffering from metronidazole toxicity that I didn't think to do at the very beginning, I did about 6 months in, same thing with videotaping the tremors in my hands, was to buy an oximeter. This device measures my blood oxygen saturation. When I purchased it, I was dealing with a flare-up about 6 months after my initial reaction, and it was bouncing all over the place. It was going from, the highest it would go is 97. As someone who's never smoked, who's never had anything, for it to never go above 97 was, to me, is a little odd. But it was still in the range of normal until it wasn't. Because it would also go down to 93. It would also go down to 91. It would also go down, as you see here, into the 80s, into the 70s. One time I even caught it in the 60s. And it stayed there for a minute or two before it jumped back up. And when I don't have flare-ups, this does not happen. I've checked it many times when I feel normal, and now my blood oxygen saturation is 98, 99, sometimes 100. 2 months into my initial reaction with metronidazole, I saw about 15 different doctors, including my immunologist. And to her credit, she actually did take my symptoms seriously, even though she didn't believe about the metronidazole. And she did a lung function test that I failed. She diagnosed me with asthma. I do not have asthma. And my symptoms did not improve on an asthma medication. I spent about a year of my life feeling like I couldn't breathe correctly. So that was a lot to go over when it comes to the central nervous system effects. So now we're going to be talking about the peripheral nervous system effects. Unfortunately, there's no systematic review that I could find when it comes to neuropathy and metronidazole. However, there are several pieces of medical literature that go into patients who have suffered from its neuropathy, either optic neuropathy, polyneuropathy, peripheral neuropathy, however you want to say it. These are the forms of neuropathy that can happen due to metronidazole toxicity. It's a burning, tingling numbness in the hands and feet, possibly leading to the face, arms, and legs. This can eventually lead to nerve damage throughout the body. This includes torso, back, head. It can be a sharp, jabbing, throbbing, or burning pain. Usually that burning pain with metronidazole toxicity is almost like an electrical pain, like you're getting electrocuted a little bit. Sensitivity to touch, lack of coordination and falling. If you can't feel your nerves, it's difficult to walk. And muscle weakness. Optic neuropathy is damage to the nerves of the eyes, leading to compromised vision. Both these first top categories are listed on the FDA label. Tetanus, also sometimes pronounced tinnitus, I prefer tinnitus, is ringing in the ears, and in the case of metronidazole toxicity, is most likely due to nerve damage to the auditory nerves of the ears. This is something that I have, and I know several other people in our support group that are also suffering from tinnitus. Now, just because one person suffers from tinnitus doesn't mean that somebody else will. Your story is not my story. And then there's autonomic neuropathy. So this is the autonomic nerves that are affected, which can cause dysfunction of the autonomic nervous system. I will tell you right now that when it comes to recovery, the neuropsychiatric issues dealing with your altered mental state, anxiety, depression, insomnia, these types of issues have the best chance of a full recovery. Next on the list, and I'm tying them together, is autonomic dysfunction and cerebellar dysfunction. I believe that these two are about tied when it comes to recovery. It's not quite as good as the neuropsychiatric, but it's also still a very good chance of a full recovery from both of these. But when we're talking about neuropathy, nerves do not heal the same way that the brain heals or the body heals. The brain heals itself differently than the body, but it can heal. Nerves can also heal, and in a lot of cases they do, but it's very slow. It's a very slow process for nerves to heal. And sometimes you don't see a full recovery from nerve damage. I know this from my own experience. I have ringing in my ears. It is a lot less than it was when I first suffered from it, but it's still there. And if you are suffering from neuropathy, there is a chance that you will have a full recovery, but there's also a chance that you will see improvement, but not a full recovery. It does have a less chance of a full recovery than the other symptoms of metronidazole toxicity, I'm sorry to say. What is going on here that is causing this neuropathy? And we'll discuss in the next video when we really break down why this damage is happening, is that metronidazole can cause damage to something called the myelin sheath. When it comes to the myelin sheath, basically what it is the nerve's protective coating, kind of like rubber around a hot wire. It not only protects everything around the wire from being electrocuted from the wire, but it also protects the wire from its own environment, because the wire is very thin and fragile, and so are your nerves. So if the myelin sheath is damaged and that nerve is exposed, you can get odd sensations, tingling, or if you have nerve damage where the nerves themselves have now been damaged due to that exposure, it might cause death to the nerve and it might cause numbness. And if you're going through that, I am truly sorry that that's happened to you and you're struggling with that. The last symptoms that we're going to be talking about in this video, and I don't really consider them symptoms, they're more outcomes, are going to be the most severe outcomes of metronidazole toxicity. And those are long-term disability due to collective symptoms, liver toxicity, coma, and death. As I said in the last video, I do not know of anyone who was taking metronidazole, experienced a severe reaction, stopped taking the drug, and then a few days, a week, a month later, they died due to metronidazole toxicity. So what is indicated in medical literature is that when somebody suffers a severe enough reaction to metronidazole, but then the metronidazole is continued despite the adverse reaction, that is when someone slips into a coma and potentially dies. Liver toxicity, that can happen with any drug. In fact, the most reports of any drug causing severe liver toxicity is Tylenol. Tylenol has the highest rate of liver toxicity compared to any other drug due to its abundant use. That can happen with any medication, where just for whatever reason their liver doesn't handle the drug well. The biggest concern when it comes to these severe outcomes is long-term disability due to collective symptoms. From everything I've seen in medical literature, from what we have witnessed in group, if I had to put a statistic on it, I would go with what is listed in medical literature, which is about a 3% chance of having a permanent severe outcome due to metronidazole toxicity. That number, it's 1 in about every 33 people. who have metronidazole toxicity. So that number is really not that low. I do want to note that in medical literature, they do not typically connect metronidazole toxicity with the mechanisms that are causing this damage that we're going to be talking about in the next video. They do not offer potential treatment options for metronidazole toxicity, and instead they discontinue the drug and then just hope for the best. They treat symptoms at best. I believe that if physicians were aware of the mechanisms behind metronidazole toxicity and implemented the appropriate treatment options for the toxicity, that this 3% would be a lot less. So that is our video for today. I know that was a lot to take in. In the next video, we are going to be discussing why this damage is happening in the first place and possible treatment options that might help with recovery. Until then, I hope that you found this information beneficial, and thank you for watching.